All right, colleagues, let's talk about one of the trickiest things we deal with, the diabetic ankle fracture. It's a real minefield, isn't it? You see what looks like a simple, straightforward injury, and before you know it, it can just spiral into a complete catastrophe, all because we might miss the underlying pathology. So today, we're going to walk through a case study and use it to build a solid framework, a game plan for navigating these really tough cases.
Okay, so let's dive right in with a case. And this one, well, on the surface, it looks pretty routine. But trust me, as we're about to see, it's packed with lessons about just how deceptive these injuries can be.
So here we have it, a 65-year-old woman, diabetic, who comes in 4 days after a fall. Now, you look at this x-ray and it's a familiar fracture pattern, right? A vertically oriented medial malleolar fracture with a trimalleolar fracture. But a couple of things should immediately set off alarm bells. First, of course, she's diabetic. That changes everything. And second, she presented 4 days after the injury and apparently was walking on it. You know that delayed presentation? That's a massive red flag. We absolutely cannot ignore that.
Right. Let's follow what happened to this patient. Her clinical course is a powerful cautionary tale, really. It shows exactly how a standard by-the-book approach can just completely fall apart, disastrously, when you apply it to the wrong patient physiology.
So the initial plan was pretty conventional, an open reduction and internal fixation. For this fracture in a non-diabetic patient, that's a perfectly reasonable choice. But, and this is a big but, the post-op course was a problem right from the get-go. We started seeing significant issues with wound healing almost immediately.
And here, this just perfectly illustrates one of the biggest challenges we face, that compromised soft tissue envelope. This non-healing ulcer you're seeing is not just a skin deep problem. Nope, this is a giant, flashing sign from the body telling us that the underlying biology, the very potential for healing, is just profoundly, deeply impaired.
Okay, fast forward to just 6 weeks post-op. The radiographic evidence of failure here is, well, it's undeniable. Look at the image on the right compared to the initial post-op on the left. You can see the hardware has totally lost its purchase in that soft osteopenic bone. We've got a complete loss of reduction. So, the first attempt, it's failed. And that means, of course, a trip back to the OR.
For the revision, the strategy was to escalate. We put in a medial plate to get a much more robust construct. And you'd think, okay, this has got to solve the problem, right? But the thing is, the underlying issue still hasn't been addressed. So even with this beefier hardware in place, the wound just kept discharging. Another really bad sign.
And here we go again, the second failure. It's screaming that this fracture is converting into a full-blown Charcot neuroarthropathy.
So, this is the crucial question, isn't it? We have to ask why. I mean, why did 2 separate, mechanically sound fixation attempts fail so spectacularly? The answer, as it turns out, was hiding in plain sight. It was a diagnosis that was missed right at the beginning.
When the patient was finally referred to a specialist center, they got the diagnosis: severe peripheral diabetic neuropathy. And that was the key to the whole puzzle. The loss of protective sensation is why she could walk on a broken ankle. And the altered autonomic function, that creates this insane inflammatory environment. It revs up osteoclastic activity, and the bone literally just melts away from the implants. The hardware never stood a chance.
So now look what we're dealing with. The management had to be escalated dramatically to a full-on limb salvage procedure. What you're seeing here is a tibiotalocalcaneal fusion nail, a TTC nail, to stabilize the ankle and the subtalar joints.
This case is it's a perfect, if painful, illustration of why we need a systematic framework. We have got to move beyond just looking at the x-ray, at the fracture pattern. We have to start by rigorously assessing the patient and stratifying their risk right from the moment they walk in the door.
And the absolute most critical first step is this classification. It's a simple question, but it's everything. Is this uncomplicated diabetes, or are we dealing with complicated diabetes, with end organ damage like neuropathy, vasculopathy, or nephropathy? Making that one distinction will completely change your entire treatment algorithm. It's that important.
So how do we make that distinction? Well, a thorough history and a really good clinical exam are absolutely paramount. We have to be detectives here. Ask them, could you walk after you fell? Are you having any burning or tingling in your feet? And then, on your exam, you have to do the work. Get out the monofilament. Check their pulses. Look for those autonomic signs like shiny, dry skin or loss of hair. These are the clues that will unmask that high-risk patient.
Okay,
So how does all of this actually guide our surgical decision-making? For that high-risk, complicated diabetic patient, the whole thing boils down to one central question. Can we get away with an anatomical fixation of this fracture, or do we need to accept the biology and go straight for a fusion to get a stable, lasting result?
Now, to help us make this really tough call a bit more objective, we have tools we can use. One of the best is the Adelaide Fracture and Diabetic Ankle Score, or the AFDA score. Basically, it's a system that quantifies the patient's risk factors, and it gives us a much clearer indication of whether we should be thinking fixation or going straight to a primary arthrodesis.
Now, take a look at this scoring system. What's really interesting here is the weighting. Notice how some factors get 2 points each: peripheral neuropathy, vasculopathy, a previous Charcot joint, and an HbA1c over 7.5. That's no accident. These are the heavy hitters, the really powerful biological drivers of failure, and the score, quite rightly, gives them some serious weight.
Okay, let's put this score into practice. We'll take another case to see how this works. We've got a 40-year-old woman with a trimollular fracture, and she presents with a whole constellation of high-risk features. She has no neuropathy, she has nephropathy, she's obese, and her HbA1c is a whopping 10. A real challenge.
So let's run the numbers. We give her 2 points for the neuropathy, 2 more points for that crazy high HbA1c, 1 point for nephropathy, and 1 for obesity. Add it all up, and you get a total score of 6. Now, the literature is pretty clear on this. Any score of 5 or higher means you should be strongly considering a primary fusion instead of trying to fix it. And this case just brilliantly illustrates the power of using this approach. Now, in this patient's case, an initial fixation elsewhere had already failed. So the decision was made to go straight to a TTC fusion. And look at the result: a solid, stable, plant-to-grade foot. I mean, the sole is flat on the ground, she can bear weight stably. By correctly identifying her as high risk and choosing the right procedure, a successful outcome was achieved. We avoided that whole devastating cascade we saw in the first case.
Okay, so what does this all mean? We can take all of these principles, the risk stratification, the clinical assessment, the AFDA score, and we can distill them down into a clear, actionable algorithm that you and I can use to guide our management in our daily practice.
And where does this algorithm start? Well, it starts with that crucial first step we've been talking about: classifying the patient. Is it uncomplicated or is it complicated? And then, if it is complicated, the next question is, with or without neuropathy? That's the key subclassification. Getting that single decision point right sets you on the correct pathway for everything that follows.
And once you make that initial classification, the rest of the pathway becomes pretty clear. For your complicated cases, you calculate that AFDA score, and you have to counsel the patient extensively about the high risks involved. Now, if the score is low, yeah, you can consider a rigid internal fixation, but with prolonged immobilization. But if that score is high, 5 or more, then primary arthrodesis has to be your main consideration. You know, at the end of the day, it's about treating the patient's physiology, not just the fracture's personality.
So what's the big takeaway here? It's this: we absolutely have to look beyond the radiograph. A diabetic ankle fracture isn't just a local injury, it's a systemic event. By systematically assessing the whole patient, by stratifying their risk, and by choosing a procedure that actually respects their underlying biology, we can get ahead of that devastating cascade of complications. And that's how we can successfully and safely navigate this management minefield.